on the sidelines of Tennessee in the Southeast Conference. But I think he did it one better being head coach at Wreckham Tech. And so we're really excited to see, hopefully football will happen this year, but to see his second year with the Red Raiders. And then Spate Grimes. Spate's an old resident of mine. Spate, thank you for being at Tech and doing so much for the residency program with Dr. Jenkins. The program directors, as Dr. Brindley will mention, program directors and what they do for the residents is so critical for our success. And Spate and I both went up with Mike Coughlin. Spate certainly does more foot and ankle than I do, but I had a great experience with Mike up in Boise, and Spate was able to get up there as well. I really want to congratulate the fives, Matt, Ian, and Kevin. Congratulations. I've known some of you all very well, and I also want to congratulate the fours and the twos. ACGME requires research, but even if you don't go into academics and you're in private practice, you still have to research a topic. You have to change your techniques every 7 to 10 years. And it's very valuable. And here I am as a PGY 3 or 4 during residency talking about some podium paper that only got accepted as a poster. So it's extremely important, and I'm excited to listen to the talks today. My story is I'm a Westerner. I was born in New Braunfels, Texas. This video is from what's called the Estates in New Braunfels. I grew up there and then moved to near Aspen, Colorado for junior high and high school and college. And Trish and I still have a house in New Braunfels. And after my training out east, I moved back west. I was in San Antonio for 10 years, and now I've been at New Mexico for 20. I took care of UTSA Roadrunners for that 10 years, and I've had really 4 amazing decades. And I want to show you a picture from my med school application in 1979. And that 10 years of med school and residency was great fun. And if the residents can see, it says not negotiable. You can't believe, but there actually was direct deposit in 1985. But not negotiable has nothing to do with cash in this check. It has to do with you're going to be on call every other night. And you were on call every other night for 2 years during that time. And residency is so much better. And trust me, every other night call, you can't even really do it. So what they did out east was you were on call Thursday, Friday in the house at the same time, and then or Saturday, Sunday, so you could at least have a few days off. And we'll talk about how much better residency programs are than what it was when I went through them. And then just a few words about COVID-19 and the recent crisis that we've gone through in this country. There have been many changes, and I think some of them are very, very good. And remember, the COVID is really just the beginning. And for the high school students have been super disappointed. My residents were super disappointed on the graduation couldn't be the same. But you should be very grateful because it gave us an opportunity to change how we practice and how we become more safe. And indeed, I have friends at Peachtree Orthopedics in Atlanta that called me. They did not furlough any employees. The doctors took a 50% pay cut. They got the triple P from the federal government, and they kept functioning. And here at UNM, in my department, although I'm university-based, I'm very proud we didn't furlough anyone and that we were able to continue people's paychecks. And I think for the residents that are going into practice, even though it seems a total change in the amount of cases you got to do because elective cases were rescheduled, it really is going to make you a better practitioner in the long run. Here's Trish and me. New Mexico, if you do a fellowship with us, we welcome you. Tent Rocks, and it's a beautiful area for you to spend a year and get extra training here in Albuquerque. So the topics today, not so much academics, but I want to talk about sports and trauma. For 30 years, I've done sports and trauma. And I don't take a ton of trauma call anymore, but trust me, that top picture on the right in 1995, that was a lot of trauma back then. And you'll see that picture down the road in this talk. And I think for the residents and all the faculty that take general trauma call, trauma just makes you a better surgeon. And I think I'm a much better sports doc because I've dealt with trauma over the years. Both of these images, the middle one of the bilateral femur fractures, there was an arterial injury on that side. On the side that I did the retrograde nail on that we had to revascularize, the vascular injury came from that spike of bone. And trauma is a superb way to be trained in orthopedics. And so some of this will be lessons learned that we talk about. And remember, to the residents and all the faculty, our stories are really our family and friends, but colleagues, and especially our colleagues that are residents and fellows. You can see Dr. Ferguson on the bottom right, but if you look right above his head to the right is Andy Veach's mouth open up because he couldn't believe that UNM was winning a game, I think. But the point is, our colleagues, residents, and especially our fellows really tell our stories about who we are. So just to talk a little bit about multi-lig and knee dislocations, I do still a fair number of knee dislocations, and we participate with the Pittsburgh STAR trial. Remember, a multi-lig knee is like an ACL, MCL, and it can dislocate. You can have a dislocation with the ACL or PCL intact knee, but really knee dislocations are by cruciates. And there's been a lot of discussion over the past, I'd say 6 to 10 years to combine all multi-ligs with knee dislocations, but they're different things. And a bicruciate is very common because of extreme sports and four-wheelers. And remember, half reduced spontaneously. And in the 70s, it was thought to be 1 in 3 was the vascular injury, but now it's basically just 4%. And with mixed traffic worldwide and motorcycles becoming very commonly used, knee dislocations are just a higher incidence. And so spontaneous reduction happens half the time. And here's a patient that came in. You can see there's something going on in the eminence. It looks like there's at least a cruciate torn. But when you do a stress view, it's a KD3M. ACL, PCL, MCL are torn. And so these type of injuries where you have a large amount of knee swelling are critical things to find in our multi-trauma patients. To classify things, and this is a little slide I put together for you. Position is really nowadays historical, except for the posterolateral knee dislocation. Here are 3 anterior knee dislocations. They couldn't be more different. The top is a high energy bicruciate injury. The middle is a football player, a high school football player that dislocated and came into the hospital like this. He was reduced and his PCL's intact. And look at the bottom right. That's an obese patient. That's an ultra low velocity dislocation. You can see how the femur is driven down the back of the tibia. And so anterior is not as useful as knowing what is really going on. Now, posterolateral dislocation is still a critical thing. This is a patient of mine who's now an American Airlines pilot. He was an Air Force pilot at Kirtland. He had an invaginated MCL. So you see that medial furrowing over here. That basically makes it a area of necrosis. It's basically a surgical emergency. This was a KD4, all 4 ligaments were torn. And I staged him and got him fixed, and he's very functional now. But PL dislocations with that medial furrowing, you can't reduce it, has to go to the OR immediately. Velocity, again, for the trauma attendings and all the folks of us that do trauma, sports calls it velocity. It really should be energy, but high velocity is trauma. Low velocity, Don Shelbourne called that as sports, and ultra low velocity is Freddie Azar from Campbell Clinic in 2011. And I find these patients the most fascinating. You know, they're difficult, they have a high complication rate, but you have to operate on all of them. They usually have a BMI of greater than 40, but look at this, 40% have a neurovascular injury. And look at this bottom right image here. With that femur driven that far, you understand why you get 40% neurovascular injury. And if you don't operate on them, Your Lisham scale is 21 versus 74. This is a football player that had a MLI that dislocated that we reduced on the field and fixed him, but his PCL was intact. And then lastly, the CATIE system. And this is what a little bit of this talk is about, because in 1994, I published it in San Antonio. So just to go back in time a little bit, I wasn't on call. I was on call every fourth night for that 10 years in San Antonio. And it wasn't San Antonio as much as it was an era. The era was that we took a lot of call. Call was not paid for. And call was really shunned. It still is to some extent, but since we have trauma rooms and we pay for call is much more doable. But a trauma surgeon needed my help. I was getting ready to scrub in on an ACL in a basketball player. So I put a short hold on the ACL and I walked into the room. I saw this x-ray up top and I saw this image at the bottom. And this was an arterial injury that they had opened up through a posterior medial approach. I basically was able to reattach a peel-off lesion in the MCL. And then 6 weeks later, I reconstructed his ACL. And at that time, I realized I couldn't classify it. It's perched. It didn't have anything classifiable. Now, please the residents do not be critical. We didn't do spanning X fixes in 1992. You'll see one from 1995, but spanning X fixes and damage control orthopedics maybe came more in the late 90s, early 2000s. And I put a Steinman pin through the eminence, took that out at 10 days, and then reconstructed everything later. And remember, this is one lesson learned that we've known for many years are the 3 A's. It's availability determines a great doctor, more so than affability, and certainly more so than ability. But all 3 are important, and I was available on this case. So the facts at the time, we couldn't classify it. I didn't know what it was. It wasn't anterior, posterior, it wasn't anything. There was 2 camps. Jack Houston discussed rotatory instability, a pivot shift, and most commonly anterolateral instability, which he felt was a tearing of the anterolateral ligament. Frank Noyes was more of the camp of what is torn. And there was some really heated discussion between these 2 superstars. And in reality, the Kennedy classification was more of positional, and I just trained with Noyes. And so I decided, let's just classify things on what is torn, and it would cover spontaneous reductions and cruciate intact knee dislocations. Now remember, it was an era of limited teamwork at the time. In the 80s and 90s, cases weren't shared. People didn't scrub in together a lot, or at least that often, more so than just a resident scrubbing in. And mentorship, and this is a big lesson, mentorship really wasn't focused upon, and I'll talk a little bit more about that. So by that afternoon, I just got a napkin in their cafeteria and I wrote out the CATIE classification. I simplified the corner as collateral and corner. So an MCL would be that and the posterior oblique ligament, and the posterolateral corner and the LCL would be one of the sides. So you have different types. So here's a football player with a PCL intact knee dislocation that all he needs is an ACL done. Here's a CATIE 3M where all 3 ACL, PCL, and MCL are torn. Here's a CATIE 4, all 4 ligaments are torn. This young lady I put in next fix about 15 years ago and then reconstructed her later at a different time. So I published this in 1992, and this is for all the 4s and 2s giving their talks. I published it. I thought it was a great idea. I heard crickets. No one talked about it. Nothing happened. But I didn't understand until later that someone had written that paradigm shifts, it was described by this fellow Thomas Kuhn, K-U-H-N, 1962. Paradigm shifts are new ideas. Let's say a Lizaroff X-fix, let's say a slap tear. They really take 7 years for them to occur, and you really need an advocate. So I needed an advocate to push this idea forward, and that person came about it. when I was in New Mexico. It's funny, I actually read this book in college, but had forgotten about it. And it also points to the fact that we need to reread our anatomy before going to the OR each day. So Bill Clancy in 2000 was my coon advocate. He came to me and said, I love the idea. He presented it at Sun Valley that year. And then when I moved to New Mexico, Dan Washer and I collaborated, and he came up with a KD5, which is a fracture dislocation. Now, KD stacks up pretty well in data since we published it. In 2015, Ned Amendola published that KD3 and greater have a high rate of stiffness. KD4s fail. In a meta-analysis by Everhart, return to sport is pretty well predicted. If it's greater than a KD3, you have a hard time getting back to sport. And in Bakshi in 2018 in the NFL showed that a KD1M, like an ACL, MCL, has about a 44% chance of returning to pre-injury level in the NFL. But a KD3L, an ACL, PCL, postal outer corner, that's 19% or less, or 1 in 5 would return to the NFL. And then this is a player of mine, Dan Ferris, gives me permission to show these pictures. He played in Lebanon and in Europe professionally after UNM, and he had a multi-leg knee that we got him back to functioning very well after reconstruction. And then sometimes you just get lucky. With this KD system, I think it was a good idea, but there are some limitations to it. It always doesn't go in line with trauma. For instance, you could have a KD1 where there's a PCL, MCL, and that's a pretty high energy injury on a motorcycle, whereas an ACL, MCL in a football player is definitely low energy. And our initial discussion was that 1 through 4 was increasing energy. But it's been an interesting study. So where is Mark? Some of you may have read this article. Dr. Ferguson shared it with you. It's from OJSM. KD research is hard to do because knee dislocations, these patients are hard to follow up. But we found him on Facebook of all places. He came to Albuquerque. We flew him there. He's now 50 now. We're gearing up for his 30-year follow-up check in 2021. He's very grateful. But his function was quite good. Here he is at 6 years with the cutoff shorts at the top with excellent knee flexion and function, but you can see some narrowing of his medial compartment. Here he is in New Mexico in 2013 at 22 years. He's got a little multi, almost tri-compartment DJD, but in New Mexico, he had excellent function. He had full extension, and he had only lost about 10 degrees of flexion. And those of you that would consider coming to New Mexico, here's one of our bright stars in Albuquerque, Dustin Richter, who does a lot of research currently. So what did I learn? So the first decade of practice, I hate to say, felt just like residency, except I didn't have all my resident friends from the roast. So doing residency without residence friends is tough. I had little balance. I had 5 children. I still do. They're lovely kids. But my typical call night was this that you see at the bottom. I started operating on this patient at 12:30 at night and finished at 5:30 and then worked the rest of the day. And I really questioned my career in academics. My priorities were right. I really focused on the family. I did not play golf, I think, but maybe 2 times during that entire decade. Now that my kids think is a funny sacrifice. But after this time in San Antonio, I really wanted to make a change. I really wanted to make academics more viable. And I think Dr. Brindley and others, we've led this way in making academics a real way to practice, or what we might call private-demics nowadays. And in addition, I wanted to be better. So just for the trauma folks to show that I can do a spanning X-fix, here's her lateral. She had a really complex fracture pattern, all open. I washed everything out. I spanned it. Then I put some flexible nails up it, converted to a hybrid X-fix with an Alizaroff. And I actually did her medial gastroc flap at the time because I did a lot of those at that time. And Jaime Garza, my plastic surgeon, worked on this area of her leg. This patient is extremely grateful. Her father's a city councilor in San Antonio, and they send me a Christmas card every year. But Christmas cards sometimes, you know, if you're working all the time, is sometimes not enough. And I just wanted to make myself better. And one of the things I did early on in San Antonio was find a mentor. I'd come from Baltimore, and I didn't have a lot of mentors in Texas. Jack Henry was an excellent mentor of mine in San Antonio, and he was up at Tech. And Jack completely supported me all the time in San Antonio. And Kerry Windler in Austin as well was a great mentor up there. And I think I started to move into the direction I wanted to go. But when I talk about lessons learned over the next few slides, and then I'll finish up, I don't want to sound preachy. I don't want to sound like the state champion in Friday Night Lights to go get one of these state championship rings. I've learned a lot, and I've made mistakes over the years, but the things I've learned, you really need teamwork. And teamwork is now called collaboration, but it is extremely important. And I will not do a project unless I collaborate with somebody else, with another partner or two partners or med students. Collaboration is critical. And this is something that you really need in practice, and it's professionalism. I think I found myself to be professional throughout my career, but as the residents that go out and finish now, your professionalism, studies have shown it's tied to your outcomes and how you handle patients and how you handle yourself. I came up with this goofy little acronym called POISE: professionalism, outcomes, integrity for sustainable excellence. Remember, professionalism comes first. In a study out of Vanderbilt with general surgeons, professional general surgeons have a much lower complication rate than unprofessional surgeons. And then remember this, you need to be open to change. I've actually been open to change and doing different procedures over the years, but my pandemic motto for all the residents in Albuquerque was be flexible and positive, and I think that's helped tremendously. And here's a picture of me outside of Baltimore City Hospital when I was a PGY3. Whether you go into academics or private practice, you need to be a leader, and you have to have skills to be a leader of emotional competence, which is really self-awareness. You must have business acumen. There's many complaints for the residents. There's many complaints that you're not educated enough on business, and I understand that. We really focus that at UNM, and we try to teach part about the business. But some of it is you're going to have to read it and study it and be mentored on your own when you go into practice. And then lastly, every practice, every academic department, you have to know your culture. Everybody's culture is different. And to be an effective leader, you have to have emotional intelligence, business sense, and you must understand the culture of that group. And all of us through residency, we build on this ability of resilience. You know, resilience is how you handle setbacks. And the pandemic was one huge setback. And I think your resilience will only grow with time, but resilience is a key thing. Your grit, I think, is an important part. And then fill in your gaps. You know, if you want to be a great academic leader, you should read Good to Great. If you find that maybe your emotional and your competence may not be where it is, I would start with an old school book like Dale Carnegie. And then business acumen, this book, Accounting 101, was one of the first books I read when I became chair to understand things. Just a couple little last comments about money on lessons learned. Everyone should look at this slide. All residents should see this. Happiness worldwide caps out at $75,000. Now, the average debt for all med students is $196,000 plus or minus 100 grand. And so you have to make more to pay off that debt. But after a point in time of how much you make, it really is what you save and not what you earn. And then lastly, and I point this out to all the finishing orthopedic grads, orthopedics has excellent metrics. And the reason why hospitals want to hire orthopedic surgeons is because there's about a 7 to 7.25 multiplier for fees. So if you do an ankle fracture in an outpatient surgery center, and you charge and collect $1,000, that surgery center will collect $7,200. And so orthopedics creates great downstream revenues for any institution. And so educating the hospital on these things and looking at your numbers are extremely important to know your downstream revenue. So when you learn a business, you can do the accounting, Excel workbook for dummies, but I tell you the best way is to find a very good mentor with integrity to teach you business. Mike Coughlin in Boise, Dr. Grimes will tell you how great of a businessman he was, and I learned a lot from him as well. So lessons learned, I keep learning. You have to keep getting better. Every 7 years there are changes, and I learned about 4 years ago from Bruce Levy when I do multiple legs, but now I write out my surgical plan for my multi-leg before I do it. And this is the inlay PCL approach that Dr. Ferguson sent you a paper on, published from 2014. And then furthermore, ACL revisions. Dr. Washer spoke to you all 2 years ago. When Dan and I were in residency and even in fellowship, we did not know about increased posterior slope. And I've done almost a dozen deflection osteotomies now, where
just
you
need one
where
pair
you
of
read
scissors.
this.
We don't need two scissors. It was so
And here's
funny.
a
It was so funny. I was like, tijeras.
Oh, sorry, I'm speaking Spanish. This is in Argentina, where I did one of these deflection osteotomies.
Picture.
And it's an extremely useful operation. But if I hadn't continued to be educated and be flexible and learn, I don't think I would have ever gotten the opportunity to do deflection osteotomies or a modified Lemaire. And to this point, several of the ex-fellows come back to Albuquerque. Dr. Ferguson, you're always welcome. And they come back and do a few cases. Some of the folks have sent me patients, and I've taken care of them together, and we've operated together. So if I can ever be of any help, or Dan and I or the partners can be of help with doing cases, we would love to look at them, email us, and we'd be happy to discuss it. And then lastly, when you focus on balance and happiness, you're going to really be much more satisfied in your career. And life balance is not going to a Japanese temple. This is a beautiful Japanese temple in Kyoto, but it's avoiding this exhaustion and cynicism and feeling of ineffectiveness. And the things I learned, and I really tried to make it happen, especially the past 20 to 25 years, is I like to work around like-minded colleagues where we work, so we have an idea of family and balance. I really set priorities. I occasionally have to say no to things. And friends are extremely critical. You never want to feel alone. And sometimes you have to seek help professionally. It may seem like a weakness, but when my first few years as chair, I was bombarded with people being very difficult. And I actually sought some help from some friends and got some advice, and it really helped me a lot. So I highly recommend that. And remember, you must have outside interests. You just can't do orthopedics, or you'll fall into this 50% burnout trap that we see in urology and orthopedics. Lastly, mentorship is really important. Your friends and collaboration. This is a principle of mine from Colorado, Glenn Stott, superb mentor. Here's Ned Amendola. He's now at Duke, great friend and mentor. Dan Washer and I, you have to have a really good partner, and you really need to create a team. And Trish is an extremely integral part of my success. And then last but not least, as a group in our fellowship, this is a chronic hamstring. Patient was referred to me for reconstruction with an Achilles tendon allograft. Here you see Dustin Richter. You see both fellows operating. There's Dan, and I'm behind Dr. Heidi Smith doing the reconstruction. And so I really like collaborating and having friends with my daily operative work. So things are really better. In 1984, I was told, answer your pager, you're here to work, they actually said learning, you need to do it on your own, and that you are replaceable. And in 2020, it's much better. We're more family oriented. The 80-hour work week is extremely useful. We have great support, but we're now focusing now on balance and mentorship more. And for the graduating residents, you really have to focus on that. So congratulations to the grads at Tech, my many friends. I love knee dislocations. Keep learning, really be open to change, be a leader, and always play well together. And here's a Thanksgiving card from my family in New Mexico after a big snowstorm. So I thank you guys.
Thank you.
Thank you, Dr. Skank. Dr. Skank, can I ask you, what is your most rewarding surgery? Which, out of everything you do, what surgery do you find the most joy in?
I think it's trauma room with the PGY4 doing bilateral femur fractures. You know, some big trauma case in trauma room. So I do Tuesdays trauma room. So I totally enjoy that. I'd say number 2 would be complex osteotomy, ACL revision type stuff. Maybe doing an osteotomy to correct alignment, staging it, and then later revising it with an ACL. And then in UNM, we do modified Lemaires for our extra-articular. So I like that staged reconstruction. And then you have a handful of patients that have had terrible injuries that were unsuspecting victims, and helping those patients, that's very fulfilling. So I didn't give you one, I apologize. I gave you 3 options.
That was a good response. Thank you.
I have a lot of coaching from Friday Night Lights with Billy Bob Thornton. I'm sorry, I had that one, Show Me the Ring. The other I love to talk about is when Billy Bob, as the coach, you know, is mentoring his quarterback and says sometimes life just gives you the short end of the stick. And I also think getting the short end of the stick sometimes and making it into a positive is really a very useful experience in what we do.
Hey, Dr. Skank, it's Kevin West here. Good to see you.
Hey, can y'all call me Bob?
No, sir.
Please. I tell everybody, I introduce myself. I'm like, hi, my name is Bob Skank. It's pronounced Skank. I wish it were pronounced Clooney, but it's not. But go ahead, just call me Bob.
All right, great. Thanks for your talk. I was going to ask you. You talked a lot about happiness and stuff during your career and ways to keep that and prevent the burnout. And then there's been a big shift in orthopedic practice to an employment model versus private practice outside of academics, and that a lot of orthopedic surgeons specifically are less happy in an employment model. Have you seen that in y'all's graduates, like that you've communicated with and kept up with as they've moved on? Because myself and the other chiefs are in our job search and kind of weighing different options, and I was just hoping to get some maybe your thoughts on that.
Well, it's a good point. It's a good question. And, everybody, I would just say everybody has sometimes different needs, because sometimes people can be in a super amount of debt and they need to go out and make a lot of money right from the start. So if you're in an employed hospital position, I'm just going to talk numbers. I hope people don't get upset. You talk, a hospital employed position, you'll make between $600,000 and $850,000 a year, when you have work RVU incentives. But if you go there and you're the only person there and you're not like-minded, it's only going to last 3 to 5 years. So to your point, the hospital employed model might be a stopgap measure to get your feet on the ground, make some money, put some money in the bank, and pay some things off. But if you can get in with a group of people that are like-minded, Jan Gilmore at Presbyterian, there's a bunch of hospital employed orthopods. Jan, Jimmy Clark, Johnson Patman, and a few others. They work really well together in that system because they're like-minded and they share. I think that we've tried to blend that model a little bit in academics. So in academics, we try to get people to 4 to 450, maybe 5, and that means you're working pretty hard. But we're like-minded, and we have really good teamwork at UNM, where we hand off fracture cases, we support each other a lot. So I think your happiness and burnout avoidance really involves working with like-minded people. And you got to have people that have your back. In residency, your residents have your back. So don't forget that when you go out into whatever job you're in. Is someone going to have your back? And we were complimented here because we have a small community hospital where we do a lot of surgery with the fellows. But patients that are transferred out there from UNM Ortho, we were complimented because they just get taken care of, because we've created about 6 or 8 of us that we just work as a team. And so it's a great question. Certainly, probably the biggest amount of money you could make is in your own hospital, surgery center owned practice. But it should be with a group of like-minded individuals, because I've seen those groups also blow apart. A friend of mine in Amarillo, who was my resident in San Antonio, so I won't say who he is, a great guy, but he and one of the residents from San Antonio split up, and he told me that they went through a painful divorce. And sometimes that happens in a practice. And I don't wish that on anybody, but it's really cool to see people that go into practice together that were friends as residents and continue that camaraderie. We have some of that at UNM Ortho, because some of our grads stay back and work here. So, and I think it occurs at Tech as well. Did that help you answer that question?
Absolutely. Yes, sir. I was just muted so that I wouldn't have background noise. Yeah, that all makes sense. So thank you very much. Absolutely.
Money isn't everything, except if you have 300,000 in school loans, then it becomes pretty significant. Okay.
I understand completely.
Yes, sir.
Almost to the dollar.
To the dollar. I know. I don't mean to be guessing so accurately. Other questions? There's got to be some. I wish I could have been there for the roast, but.
One thing I was going to ask you about, more about your knee dislocation stuff. So we found when I was working with Dr. Ferguson on the sports service, we did quite a few multi-legs relatively. And, it seems like the private guys in town are really not very likely to take those cases and are more likely to refer them to us, I guess, just due to complexity and the time it takes to do that case, and not having the maybe available help of, someone else who can help you get through the case. Have you found that to be true in Albuquerque, where y'all are getting all those high level or do they just come to you naturally because of y'all are level 1?
Some of the folks in town fix them, but most of the time they send them to us. But, I must admit, my friends in Las Cruces that take care of New Mexico State, because I do a KD3L well, they send me all their ACL posterolateral corners and laprods. Because once you get outside that ACL, now an ACL and an extra-articular are very easy to do in combination. So that's going to become part of your handiwork, Kevin. As you move forward in this, you're going to do an ACL revision and a modified Lemaire or anatomic ALL. But doing a laprod, perineal nerve release, reconstruction, people in private practice don't want to do that as well. So I think you can carve it out initially with bicruciates and patients that, maybe don't have the best social circumstances. Because with any bicruciate, you've got to look at their social circumstances to see if they're going to do rehab and function post-op and be and participate in their recovery. I think that's another reason why some of the folks in private practice, it's just much easier to do an ACL in a high school student and not have a 20% chance of a manipulation. But we do so many multi-legs, it's kind of an interesting sort of thing. Like when you go to Luby's or Furs, I don't know if you've ever been to Luby's, but sometimes the options are awesome that you want to just try everything, but having multi-legs in your practice is very interesting. And if you keep doing them regularly, then it becomes just like doing a complex rotator cuff. That's how we look at them. And so when people refer them to them, we totally enjoy doing them.
Thank you.
I drove through Big Spring last week. I went down through Brownfield, La Mesa. I almost made a left and headed north to Lubbock and see you guys, but I had to go to New Braunfels to check on a remodel. And the Luby's was closed in Big Spring. I didn't know that. That was kind of disappointment.
Big Spring is advertising for tourism here in Lubbock. There's billboards up there for, I'm not sure what the reason, I guess Spate would tell us what the reason the visit would be.
Hey, Bob, I had a quick question. So you talked about call and balance, et cetera. Do all the faculty at UNM take call? Are they required to take trauma call? We recently kind of changed our schedule around here where most of the faculty are rotated in. They can trade that off, but in some ways, to me, it seems somewhat beneficial for everybody to take a little bit of call so they can sort of, stay in the game and sort of understand what it's like to be on call continue at different times. So what's your thoughts on that?
Oh yeah, everybody's on call except when you hit, 59 and a half. We allow those people to go off call because some of us had been taking call for so many years. So like Dan Washer doesn't take any call anymore. But like I occasionally will take some call, but yeah, everybody takes call. We came to find though that we felt our sports folks and the people that were trained at UNM, we did probably half the femur fractures. And so we decided to take more of a responsibility and create a service line. So although call is split up and you're on every week, like 10th weekend, something like that, we pay for call. It's not a lot. So that if you do trade a call day, it's only worth probably $750, and a weekend call trade is only worth $2,000. But we feel that it would be impossible for our 4 trauma folks to take every 4th night. You just couldn't do it. Like I did it in San Antonio for 10 years. I do not recommend that.
Yeah, I think Dr. Krim and I took about every 4th night for how many years? 10? I did it for 12 years.
I did it for the first year I was here. In the last, year and a half, we've slowed. And
again, you start to, after about 12 years or so, you start to falter a little bit. It starts to, I understand what you're saying.
Well, and also, do you see this thing here? I kind of have sort of PTSD when my pager goes off sometimes. So I only like to be texted. I mean, I have PTSD from 10 years in San Antonio, and it wasn't San Antonio. It could have been anywhere in the United States. It's just there was not enough people to take call. So it should be split up with everyone. You should have a trauma room so that, only thing that goes to the OR at night are things that have to be done. But you got to have your trauma team be able to sleep at night. And then, because I think that's a good practice, is to come in every day, do rounds and see, you'll have some days where you have your scheduled acetabulums and your pelvic fractures that are on schedule, but you got to have a trauma room where you can run a couple rooms. That's where we have struggled, to be honest with you, here at UNM. After what happened out east, where you can't run 2 rooms simultaneously, we have to have an attending for every room. And so that slowed us down a bit. But what happened with COVID, to be honest with you, is COVID allowed us to sort of rework the system so that we had to go into surge teams. And we just did a ton of trauma, because since all the elective practices in the Albuquerque area shut down, all the fractures came to the U. So we did about 50 fractures a week, every week during COVID. And we'd run 4 rooms at a time because we had all these attendings. So now that we're moving post-COVID, we're trying to figure out a way so that we recruit more attendings to help on trauma room days. And we'll let y'all know how that goes. But yeah, everybody's got to share in the call. You can't. Dr. Ruth at University of Arizona and his team take all trauma call at that busy trauma place. I don't know how they do it.
Have you guys changed your policy regarding 2 rooms? I mean, did you used to allow faculty to flip-flop rooms? And you mentioned some of the changes that happen out east. Can you go into that?
Yeah, so CMS guidelines are very strict in terms of billing, because you cannot let a resident close a case while you start a case in another room, because CMS feels that they're paying now twice for that resident. If you get my drift. Now, a physician, an advanced practice provider could close, you can go to another room. So closing and flip-flopping or overlapping, that you can do and follow CMS guidelines if you as the attending close and then you can go to the next room and it's just getting started, or you have an advanced practice closing. So that's a possibility. But yeah, no, there was some specific rules, Matt, that be able to really flip-flop and especially when you're doing infection washouts, that even a chair like me could do, like something very simple. But now we have to have an attending for each room, and we're struggling with that a little bit, but we're making it happen. But yeah, no, you got to follow CMS guidelines. And it was just out east. There was some very, very famous centers that were doing total hips with fellows in each room. And that's for like a Medicare total hip, that you cannot do if it's an ACGME accredited fellow. And to Dr. Jenkins' point, I just wanted to make one other comment, that sometimes having a fellow, a non-ACGME trauma fellow, could be useful to help cover some of your extra trauma room days so that they could start a case as well. But yeah. Oh, and then lastly, I wanted to say to the trauma folks, I'm a firm believer, and some people don't believe in this, so I don't want to insult anyone on this chat, but trauma surgeons in our place, one in particular does a very nice total hip. And so we're non-silo in that way here, that if you're really good at doing a total hip as a trauma surgeon, and you have this huge practice of acetabulums and pelvis injuries, that occasionally you're going to have to start doing total hips. Because just to Dr. West's question, some folks in private practice may not want to care for some of your adult reconstruction partners don't want to care for the trauma patient that needs a total hip. So we allow that. And there was a little bit of friction between a couple of the adult reconstruction folks and the trauma folks at UNM, but I was able to smooth that out. We can go into that at a later date.
We really appreciate you coming and talking with us, Dr. Skank. I know.
Please, Spate, just call me Bob.
Yes, Bob.
Just call me Bob. It's very straightforward. It's very easy.
We certainly appreciate it. And, you know, as usual, your life advice is really useful for residents and probably for some of the faculty. So thank you very much.
Oh, it was my pleasure. Thank you. It was just great. Great participating today.
So we're going to move on now to the residents. And we understand if you have things to go and do, but if you want to hang out and watch the presentations, you're more than welcome.
I was planning on it.
Okay. So first up is going to be Brent Albrecht. He is one of our soon-to-be chiefs, effectively is a chief at this point. Brent, are you on here somewhere?
I am. Let me share the screen. Hope everyone's seeing that. Let me get to presentation mode.
Yes, we can see your screen.
Okay. Okay, there we go. Let me minimize this. So my research project that I've been working on since intern year has been an increased compliance and cost savings with universal pre-op decolonization with povidone iodine versus PCR testing and McPherson treatment in total joints patients. Going into total joints, so this was something that I've been looking into. So no financial disclosures for me. Just a background, preventing surgical site infections in nasal carriers of Staph aureus patients has decreased the surgical site infection prevalence from 7.5 to 3.4% over the course of the last decade. Has been a real push for this. And with an annual cost of surgical site infections and total joints being over $500 million, this is something definitely worth looking into. You know, when that paper was published, the traditional decolonization protocol was to nasal swab PCR test every patient for Staph aureus for their carrier status. And at our institution, that's $261 per patient. And those that came back with a positive result, those patients were given a McPherson nasal prescription, which over the past few years has averaged about $176. This is a 5-day treatment protocol that's twice a day. And so it requires their compliance to complete all of this. Something that we've changed as of January 1st, 2017 is no preoperative testing. So there's no PCR involved. There's just a povidone iodine treatment, 4 swabs, 2 in each nostril. And this is done by the holding nurses. So it's monitored and documented. And this is a drastic change in cost with only $28 for the package of 4. So problems with that traditional McPherson protocol is the PCR and McPherson is that the PCR test again is expensive. The McPherson is expensive and can be out of pocket for that patient, and so that can be a restricting agent in their compliance. I found one article that specifically looked on just how unpleasant the intranasal treatment is of McPherson and compared to a nasal swab, and so 38% of patients found that uncomfortable, and that the compliance rate that we found for our study, just a little spoiler alert, is only 67%, and that's because it's not monitored. So solutions with povidone iodine treatment is that you completely eliminate the need for PCR testing. It's just an empiric treatment. The povidone iodine is much cheaper than McPherson. That paper suggested that only 3% of people find the nasal swabs unpleasant, and so it's more comfortable for the patient. And this is, again, completely monitored. And so as long as they didn't have an iodine allergy, this should be a 100% compliance, as this is part of our protocol. So the goals of our study was to compare the compliance rate of both of these protocols and then to evaluate a cost savings for this. So we're looking at a single center retrospective review of our joint registry. This is a look from patients from 2015 to 2018. And we looked back through the records for this. It's mainly an inclusion criteria of patients with just primary knees and hips. We left out shoulders and oncology patients for this. And then we monitored for iodine allergy, which is about a 4.4% rate at our institution. And so these patients were excluded and given the mupirocin treatment protocol and left out of the statistics. This is a little flow chart with 700 total patients. Again, our iodine allergies were excluded, and we had 412 patients with complete compliance with our change, as opposed to 312 patients in that first cohort. 101 of the 312 were positive for Staph aureus, and so 19 of the patients never filled their mupirocin, and then of the patients who filled their mupirocin, another 14 patients didn't complete the 5-day treatment, and so that has its effects on our compliance. So we found the total compliance rate to be about 67%, as opposed to 100% compliance given our exclusion of the iodine allergy. This translates to $307 for that first cohort per patient, as opposed to $28 for the second. This is $279 saving per patient, and when you extrapolate that to the 412 patients we had in the second cohort, it's over $100,000 in cost savings for the hospital and our department. So for what's next for this paper, we submitted it to COS, which unfortunately has been canceled, postponed. I don't know exactly. It sounds like they might do an online version, but that was supposed to be in Nashville this year. I need to talk with Dr. Brindley to see, kind of what the goals, if we're going to present this year or save it for when they meet in 2021. We're going to continue to collect data. We're going to go back through and get more patient demographics to make sure that we have good match patients from our two cohorts, and get more of a just to make sure that our surgical site infection didn't go up with the change in protocol, though multiple studies have shown that that the povidone iodine is actually more effective. So I don't anticipate that being a difference. And then the ultimate goal would be getting to the Journal of Arthroplasty for our publication. These are our sources. If anyone had any questions.
Doesn't sound like there's any questions. Thank you for a good presentation, Dr. Albrecht.
Actually, I have one quick question. Sorry about that. Brent, you presented this 2 years ago. Have you noticed any large changes from 2018 to now in your data? Or is it becoming more and more supportive?
No, we were kind of, we were nearing the very end of our retrospective part of it. And so I had collected for the first cohort, and I think I presented that data 2 years ago. And so the last couple of years has really been kind of getting through the second cohort. I've gone through a couple of med students. And so between the combination, that's been kind of the progress over the last 2 years.
Okay, awesome. Yeah, I just wanted to find out if if the support was growing and growing and growing as you had added patients, and it sounds like it is.
So any other questions?
I think my one question would be, in terms of if you're looking at it from a cost standpoint, it's certainly good if you can get your infection data, because that certainly will impact costs and things like that, and see that that's what you would need to offset it with, to see if there's not a difference in your infection rates. Then the cost savings are obvious. But if there is a difference, you need to see how much that is, and it's and really, you know, rate that, because that'll be pretty important to get this paper where it needs to go.
And that's been a big push from Dr. Simpson, I guess, for the future of this paper. I just there's been a couple papers that have been published on this in the last few years. Some of those in JOA, and those have shown that it's been equivalent or better as far as surgical site infection goes. So it wasn't necessarily a focus of the of our goals, and so I guess it'll be kind of secondary data just to make sure that there isn't a difference.
Okay. So any other questions?
Just one general comment. Sorry, Brent Simpson here. I was also kind of, the more I think about this is the work effort that goes into calling all the people in the McPherson and PCR wing. That was very time intensive from our nursing side as well. And I don't know if we have any kind of thing documented, but the amount of effort they had to go to in the clinic nursing time that we may not have included in our cost analysis was pretty extensive, from our pre-op folks to our clinic nurses, to make sure they got the prescriptions and ensuring their compliance. So I don't know if we have any comments on that, or you've looked at any type of study or any type of information in our collection on that.
There was one study, I'm trying to remember where it was from. I think it might have been Germany, where they broke it down into it was more for in-house patients, and that, you know, that went from even the phlebotomist collecting the blood, and I don't know, it was a huge breakdown of the added costs. And so there's been papers that have kind of shown that. As far as our stuff goes, we mainly just documented with a pre-op survey. And so most of that just came from the pre-op holding area, kind of collecting that data, but no time documented as far as effort into that.
Okay. Any other questions?
This isn't a question, but just a reminder, there is a score sheet for all the faculty watching the lectures, and so be sure to kind of record that and turn those in. So we're still going to have awards for the best research presentation.
And you can either print that and give it to Tara, or you can, if you're not here at the university, you can take the Excel spreadsheet, fill it out, and send it to her electronically. But we will need that by the end of business today, so we can award the prize, I guess this afternoon or this evening. So our next resident presentation is by Christian Doffett, another one of our soon-to-be fifth years. And he's going to tell us about a Vive soft tissue membrane for improving outcome from revision upper extremity nerve decompression surgery.
All right, thank you, Dr. Grimes. Thank you, Brent, for your good presentation. Switching from joints to hand topic, we're going to be talking about revision nerve decompressions in the upper extremity. Particularly, we've been looking at two of the most common nerve decompression procedures, carpal and cubital tunnels, but we've also looked at those with radial tunnel syndrome. Since Dr. McKay's gotten here, our volume has really increased in not only primary but revision nerve decompressions. So we've been seeing a lot of these folks in our clinics, and just understanding some of the numbers of some of these procedures that we've been doing. Carpal tunnel being by far and large the most common nerve decompression done by any orthopedic, general, or plastic surgeon. There's over 200,000 alone done in the United States, and pretty close to that many in cubital tunnels, or at least half as many as cubital tunnels. It's important to note, depending on what source you look at, there can be as high as a 25% failure rate for carpal tunnel releases, and even 19% for cubital tunnel releases. And depending on what source you cite as a failure rate, that could be anything from persistent numbness to persistent night pain, to even persistent muscle atrophy following a primary nerve release. So when these folks come to your clinic, you've got to ask yourself, well, what can I do if they failed a primary release? Historically, there have been a lot of different options, such as injections into the carpal tunnel, endoscopic revision, whereby you insert a cannula and a camera in said tunnel and look for any other scar tissue that may have been left behind. There have been historically also vein wraps, particularly a nearby vein where you unravel the vein and wrap it around the nerve itself. It's thought to be due to persistent epineurial inflammation around that nerve. And similarly to fat flaps, the idea is just to plug something in around the nerve to help calm it down. Unfortunately, with all these options, there haven't really been any long-term data or even randomized controlled trials to monitor the success of these procedures, particularly with fat flaps and vein wraps. They can come with pretty significant donor site morbidity, particularly in areas that have already been operated on. And kind of like going over beforehand, in 40% in carpal tunnel releases and 25% in cubital tunnels, even in revisions, 40% and 25% of patients will still experience persistent symptoms after a revision procedure. These are just two diagrams illustrating that vein wrap you can see illustrated here in A and B, as well as a fat flap going through the carpal tunnel. So moving on to what was the focus of our study is a type of conduit. In the past, some of the ones that first came on the market were collagen conduits, specifically things like Neurogen, Neuroflex, Neuromatrix. They have been studied as well as wrapping the nerve for revision procedures in these collagen conduits. However, they too also lack long-term data. A Vive made by the Axogen company is something that's been on the market for the past decade or so. Unlike a collagen conduit, it's a processed human umbilical cord membrane, and it's typically designed to be used as a soft tissue barrier. So it has had its success in things such as tendon repair, nerve repair in a traumatic nerve disruption, and helping prevent scar tissue from encasing those damaged structures, and specifically tendon repair where you want good flexor tendon glide. It has had some good data to suggest that it can help with tendon glide so long as there's enough room to wrap it around the tendon. The Avive membrane itself is naturally absorbed by the body. It can contain growth factors, mesenchymal stem cells, and collagen as well, all of which are thought to contribute to this anti-inflammatory and reconstitution neogenesis to the injured area and help stimulate repair or growth and repair of the damaged structure. This is just an example of this membrane. So it has this little tab up here that you can use to orient yourself and wrap it around either the tendon or in our case the nerve to help provide either if a nerve repair at the anastomotic site or at the part of compression, such as in a revision carpal or cubital tunnel. So our methods, it was a completely retrospective study in that patients who were undergoing revision surgeries for nerve decompression, specifically carpal, cubital, and to a much less extent, a radial tunnel revision. These guys were all included in our study, but folks were excluded if they were under the age of 18. They had perioperative complications that could confound our results, or if they had previous trauma or medical conditions that could predispose the nerve to significant injury, which could be another confounding factor. We took into effect a lot of the demographic aspects of each patient, such as the age, sex, and how long from their index procedure it took for them to get plugged in with us for their revision procedure. Things that we looked at in terms of was the Avive membrane helping or not were the visual analog pain scores, particularly as it pertained to night pain, 2-point discrimination or their ability to return to normal sensation in that specific nerve distribution. A Siemens-Weinstein going along with that 2-point discrimination, a Tinel site or a Tinel sign at the point of compression, such as in the carpal or cubital tunnel, grip strength and pinch strength, and as well as range of motion, either at the wrist or the elbow. And these are just a couple of figures illustrating what an intraoperative site would look like when using this Avive membrane to wrap around the nerve, this being the median nerve at the carpal tunnel, and this being the ulnar nerve at the cubital tunnel. So far, we've had about 60 patients. Over those 60 patients, 68 nerves met inclusion to our criteria. The average age was about 54-ish years. Pretty close to half and half of male and female, though we a little bit more skewed towards the female side of things. The average time to their revision surgery from their index procedure was over a year, so good enough time to know for sure that they had failed their primary procedure. And so far, since we've started doing these, we've had a little bit more follow-up than just 6.1 months, but this was the data that we were hoping to submit to the the American Academy of Hand Surgery meeting next year. The Avive was placed in these folks, and we've found that DASH scores have been attained for 33 of those 60 patients at the time. An average follow-up being, again, about 5.5 to 6 months. DASH scores being about 37.7 out of 95, with a mean follow-up of 5.5 months. 2-point discrimination, Siemens-Weinstein grip strength, pinch strength was improved in about 96% of our patients, if not at least one or more of any of those variables. In short, 96% of our patients experienced improvement in their revision procedure following their index procedure. Of course, this is limited by the fact that we have no comparison other than subjective comparison of the patient to what they had experienced from their primary procedure. So in a sense, what would be the next good step for our study would be to compare it to controls in which they do not have any kind of Avive application to their revision surgery. Although this is a pretty promising start, given that the Avive amniotic membrane is a relatively young product on the market, and it could be used relatively successfully for folks specifically who would otherwise have gone vein grafting or fat grafting, who would otherwise experience donor site morbidity from those procedures, or for folks who just, it's oftentimes not experienced in our country, but those who don't have a lot of fat stores and could have a successful fat graft. And these are our sources. And that's it for my research as of late.
Do we have questions for Dr. Doffett?
I was a little confused. What was your primary outcome you measured in the study?
So it was improvement of subjective symptoms such as pain, range of motion, overall patient satisfaction DASH scores. So as of now, we've had 96% of patients experience improvement in at least one of those categories. I haven't made a table talking about each patient in general. That would be something that I'll definitely submit to our to the meeting that we're submitting to in January. But yeah, essentially a lot of subjective things for now.
I don't have a question, but let me make a comment. There is historical data to compare to. For example, you can find papers that look at primary and revision surgeries. One of the numbers they throw out is that 79% of patients getting a revision cubital tunnel get some relief. So we just had, specifically talking just about cubital tunnel, you have to separate them out in our study, but 79% is not that great. So if we're in the 90s, on revision surgeries, that's pretty darn good. So we are going to eventually compare other published historical data on revision surgery to the results we're getting with our revision surgeries and divide.
Any other comments or questions? Thank you, Dr. Dothit. We'll move on to Jessica McGraw. Jessica, again, is one of our rising fifth years, and she's going to talk with us about core needle biopsy as a diagnostic tool for musculoskeletal tumors. Is Jessica here? Looks like, oh, there you go.
All right, Dr. Grams, I'm here. Are y'all able to see the screen?
I see your screen.
All right, so I'm talking about my project. We're looking at the core needle biopsy accuracy rate here at our institution, and also trying to determine, is it effective, and how does it compare with the published accuracy rates of core needle biopsy. And so we'll go over a little bit of the background, and then methods, touch on our results, and then talk a little bit about how our results compare with the published accuracy rates of core needle biopsy. So some things we'll touch on. So why are accurate biopsies important? What are some various biopsy techniques? And then lastly, what are the study questions that we're specifically looking at? So why do we care? So bone and soft tissue sarcomas represent about 1% of the annual cancer diagnoses in the US. That leads to an incidence rate of about 1 per 100,000 persons per year. And the 5-year relative survival rate of these is about 66%. And a death rate of about 0.4 per 100,000 people per year. And as such, a prompt and accurate diagnosis can aid in the treatment of these patients, and more importantly, it can optimize their outcomes. So how do we diagnose these musculoskeletal tumors? It relies on a handful of things. The clinical information, including patient's history, physical, some lab work, also how the tumor appears on imaging, including x-rays and MRI. And lastly, one of the things we typically do before surgery is we want to have a histologic diagnosis, and this really depends on having a biopsy of the tumor. And specifically what we're looking at is open surgical biopsy versus image-guided core needle biopsy. So just briefly, the difference between these methods. So open surgical biopsy can be either incisional, which is like taking a sample of the tumor, or excisional, where you excise or remove the entire tumor. But this can have a lot of risks, including perioperative complications from anesthesia, from the procedure. You also worry about contaminating the wound bed, and overall, this has a higher morbidity than performing a more minimally invasive technique such as image-guided biopsy. And so needle biopsies come in two flavors. They can be either fine needle aspirates, but these kind of give you an idea of what the cells look like, but they don't really give you anatomic structure. And that's where core needle biopsy comes in use, is that this really preserves the tissue anatomy. And oftentimes, the needle tracks have less contamination of the surrounding tissue. But sometimes you're limited by the sample obtained, especially for heterogeneous tumors that vary. You only see what you sample. So which do we choose? It's important to consider the location of your tumor, the suspected tissue type and tumor type, if you're looking at a bone tumor versus a soft tissue tumor. And lastly, what is your future surgical plan based on what you suspect the diagnosis to be? It's very important that we plan our biopsy in conjunction with the surgeon that's going to be excising the tumor. And of note, incisional open biopsy is often considered the gold standard. However, less invasive techniques are becoming more and more appealing because, like we mentioned previously, this can minimize patient morbidity from the biopsy procedure. Additionally, in a healthcare system, that's more and more requiring cost effectiveness, cheaper techniques are often more appealing. And if we can avoid multiple surgical procedures, that can help with that. But the main thing is that sacrificing the diagnostic accuracy for cost savings is not justified, when patients' lives are at stake. So in the literature, there's multiple retrospective studies which have looked at the accuracy of core needle biopsy. These range from, when just determining whether a tumor is benign or malignant, this accuracy ranges from 84 to 96%. And when determining specific pathology, comparing the specific pathologic diagnosis on a core needle biopsy versus the pathology at final excision, this accuracy ranges from 45 to 80%. However, most of these studies are performed at major sarcoma referral centers. So your Mayo Clinic, there's a large institution in Washington, D.C. that's published on their accuracies. And so this, really came to question what are our accuracies, because, accuracy is very dependent on the institution. It depends on the expertise of the radiologist or the surgeon performing the biopsy, as well as the expertise of the pathologist who's reading your biopsies. And because of this, we thought that it was very important for smaller treatment centers, such as our institution, to conduct self-review to determine our accuracy rates. So this led to our study questions. So we wanted to determine the effectiveness and accuracy of core needle biopsy and open incisional biopsy for determining malignancy. We also wanted to determine the accuracy of these techniques for determining specific tumor pathology, both for bone lesions and soft tissue masses. And lastly, we wanted to see, were there any major complications from these biopsy techniques at our institution? So how did we do this? So our study is a retrospective case series of patients undergoing musculoskeletal tumor biopsy, and then they subsequently underwent excision of their tumor at our institution. So inclusion criteria included all patients undergoing either core needle or incisional biopsy and subsequent tumor excision at our facility from a time period of 2006 to 2018. We excluded patients who had pre-op biopsy at an outside facility, as well as patients who had biopsies done for non-tumor diagnosis and patients with inadequate documentation or loss to follow-up. We used retrospective chart review to obtain patient demographic data. And then of note, all core needle biopsies at our facility were performed by our radiology department. The size of the core needle as well as the number of cores was at the discretion of the radiologist. And then all incisional biopsies were performed by our orthopedic oncologist. And again, all tumor excisions were performed by our orthopedic oncologist. And lastly, all biopsy tissues were evaluated by our same pathology department. So we found our patients by filtering out patients via CPT codes. So looking at our oncologist patients over that study time period, we filtered out to look at patients that specifically had a biopsy procedure or a tumor excision procedure, and this left us with 244 patients during that time period. Of these, 124 had a preoperative core needle biopsy and 23 had a preoperative incisional biopsy. Again, we filtered these out if patients had an outside core needle biopsy or outside biopsy prior to tumor excision. And then of these, in our core needle biopsy group, we looked at the efficacy of core needle biopsy, and any patients that had an inconclusive core needle biopsy underwent a subsequent incisional biopsy. Looking at the demographics between our groups, in our bone tumor group, core needle biopsy and incisional biopsy, patients had similar age, proportion of sex, and BMI was consistent between the groups. And then in our soft tissue tumor group, for both the core needle group and the incisional biopsy group, again, age and sex age was very similar, and BMI was similar without any significant difference as well. And so the outcomes that we were specifically looking at, again, were the effectiveness and accuracy of core and incisional biopsy. We also looked at the accuracy of those biopsies for determining specific pathology. And lastly, we wanted to know what our complications were from the biopsy techniques. So what did we find? We found that our biopsies are pretty effective. So effectiveness meaning that we did the biopsy and there was adequate tissue sample to determine a diagnosis without requiring further biopsy. And so in our bone tumor group, core needle biopsy was 83% effective. So that meant that 16% of that group required a subsequent biopsy. However, it was 100% effective for our incisional biopsy group. Likewise, for soft tissue tumors, core needle biopsy was 97% effective, and the incisional biopsies of soft tissue tumors were 100% effective. When we looked at the accuracy of these biopsy techniques for determining whether a tumor was either malignant or benign, in our bone tumor group, core needle biopsy was 89% accurate for determining malignancy status, and incisional biopsy group was 100% accurate. And then in our soft tissue group, core needle biopsy was 92% accurate for determining malignancy, and our incisional biopsies were again 100% accurate. And then the third thing we were looking at was accuracy of our biopsy techniques for determining specific pathology. So for example, if the core needle biopsy said chondrosarcoma, did this match the excisional pathology at the time of tumor excision? Did that also say chondrosarcoma? And when we looked at specific pathology, we were a little less accurate. So for malignant bone tumors, our initial core needle biopsy group was 73% accurate. Of note, it was less accurate for our chondrosarcoma group, as well as our pleomorphic sarcoma group. For those that had initial inaccurate biopsies or inconclusive biopsies, subsequent incisional biopsy for those patients were 100% accurate. And then in our second arm, our patients that had an incisional biopsy initially, those were 75% accurate for specific pathology. When we look at our benign bone tumors, these overall tended to be less accurate than our malignant bone tumor group, both for core needle biopsy and subsequent incisional biopsies in those that had a initial biopsy that was inconclusive. And you know, our accuracy for our initial core needle biopsy group for benign tumors was only 42%. And even of these that had inconclusive biopsies, subsequent incisional biopsy was only 75% accurate. And then lastly, looking at our soft tissue tumor group, these tended to be a little more accurate than our bone tumor group. Our malignant soft tissue tumors had a core needle biopsy accuracy of 88%, and incisional biopsies in this group were 100% accurate. And then looking at benign soft tissue tumors, these were 52% accurate for diagnosing specific pathology, and our incisional biopsies were 100% accurate. When we looked at biopsy complications, there were no procedural related complications for either procedure. These would include hematoma, infection, contamination of the biopsy tract, etc. However, there were complications of diagnostic error. You know, we did have a handful of false positives for malignancy. Of note, one of our bone tumor patients, this resulted in an alteration in her clinical treatment. She was initially diagnosed with a chondrosarcoma based on her core needle biopsy. However, at the time of excision, she was actually found to have synovial osteochondromatosis. But she was treated based on her biopsy results and actually underwent distal femur resection when perhaps she could have just had synovial excision. Additionally, we had a handful of false negatives for malignancy. So these are patients where our core needle sample suggested a benign diagnosis, but at the time of excision, they were found to have a malignant diagnosis. And One of these 4 patients actually had an alteration in his clinical treatment because of this diagnostic error. This guy was presented to our clinic with a pathologic tibial metaphysis fracture, and core needle biopsy showed giant cell tumor. As such, he underwent curettage and phenolization of this, as well as fixation. But pathology from the time of that surgery ended up showing pleomorphic sarcoma, and he ended up going on to have Mets to his groin and requiring a hip disarticulation down the road. So how do our results compare to the literature? So when we look at biopsy efficacy, those larger institutions publish an efficacy of 71 to 83% for bone lesions and 60 to 86% for soft tissue lesions. And our results are comparable, with core needle biopsy being 83% effective for bone tumors and 97% effective for soft tissue tumors. When we look at the ability of our core needle biopsies to determine malignancy, in the literature, this ranges from about 84 to 96% for both bone and soft tissue tumors. And again, at our institution, our bone tumors for diagnosing malignancy are about 89% accurate, and our soft tissue tumors are accurately diagnosed about 93% of the time. When we look at ability to determine specific pathology, again, in the literature, core needle biopsy accuracy ranges from 45 to 80% for both bone and soft tissue tumors. And our results seem to be comparable. For malignant bone tumors, we accurately diagnose 73% of those and 88% of benign bone tumors with core needle biopsy, versus our incisional biopsy accuracy rates being 75% for malignant bone tumors and 100% for benign bone tumors. And then lastly, looking at soft tissue lesions, our core needle biopsy accurately diagnoses 52% of our malignant soft tissue tumors and about 52% of our benign soft tissue tumors. And then incisional biopsy of soft tissue tumors is 100% accurate for both malignant and soft tissue tumors in our patients. And then lastly, looking at biopsy complications, we had no procedural complications. In the literature, procedural complications can range from 0 to 7% for core needle biopsy and 0 to 17% for open procedures. However, we did have a handful of patients with diagnostic errors, and of these, 2 patients had alterations in their clinical treatment due to inaccurate core needle biopsy. So in conclusion, we've determined that core needle biopsy is effective and accurate for the diagnosis of musculoskeletal tumors at our institution. Additionally, biopsy accuracy at small regional treatment centers can be equivalent to results from larger sarcoma referral centers. And the last point we want to make is that orthopedic oncologists should really know the accuracy of diagnostic procedures performed at their institution, especially if they're relying on these to guide patient care. Here's our references. Does anybody have any questions?
Jessica, do you know how many of those specimens were sent out to a reference laboratory for the pathology, and how many were done in-house?
So we specifically looked at ones done in-house. If they were sent off to like Mayo Clinic, we looked at just our pathology department's read. So I think of the like 150 or so, there were about 5 that were sent out that I can recall off the top of my head. But for purposes of our study, we wanted to know the accuracy of our pathology department.
So the 2 that resulted in significant clinical changes, they were not sent to a reference laboratory?
Those were not, no, sir.
Okay.
And the ones that did get sent to Mayo or somewhere else, those were excluded from the study?
We included those patients, but we wanted to look at the accuracy rates of our department specifically.
So you excluded the accuracy portions of the study?
Well, when we the pathology read that we used for like our excisional biopsy, our internal gold standard, we pulled the read from our department, even though there might have been an additional read from like Mayo Clinic or wherever it was sent out.
Okay.
Are there other questions?
Yes, on some of these, I thought it was interesting finding. I think the chondro sarcs had something like a 52% accuracy. Do other institutions have the same difficulty with certain pathologies as well? Are you aware of that? I just thought that was an interesting finding.
You know, there's not a lot of good literature that actually breaks it down into specific tumor type, just because they tend to be fairly rare tumors. I think I only came across one other paper that actually broke it down by tumor type, and you know, of that one paper, they just had a handful of chondrosarcs and had similar issues. I think cartilage tumors tend to be notoriously hard to diagnose by core needle or minimally invasive techniques.
Yeah, I think that'd be an interesting thing to pursue. So thanks.
Hey Jess, on those chondrosarcs, was it kind of piggybacking off Dom? Was it considered an inaccurate diagnosis if it was the wrong grade? Because chondrosarc's unique in a way in that you have low, intermediate, high grade, dedifferentiated mesenchymal. So were they wrong if the grade was wrong?
So we said it was wrong if they, so for example, some of those that were wrong, the pathologist read cartilage type lesion, like very generic read, when it ended up being a chondrosarc. So we considered that a wrong diagnosis, even though, you know, they had the right type of tissue, but they didn't tell us that it was a malignant lesion consistent with chondrosarcoma. We did not, if the pathologist read like grade 1 or like grade 2 or 3 chondrosarcoma, like a more malignant type lesion, and the final excision pathology was consistent with that, then it was considered accurate.
I got you.
I guess I'd also ask, did you do any analysis on comparing the accuracy of the groups to each other?
We tried to do an analysis. The sample sizes of each group is so small. Statistically, it was not feasible. You know, some of those groups we have like one patient.
Sure, but I mean, as the groups as a whole, in terms of just core needle versus incisional.
Other than, you know, we initially tried to do like a statistical analysis to see which factors within the groups might have contributed, such as BMI, the biopsy technique, and also within those looking at like core needle size, like size of the needle and number of cores taken. And those did not show to be statistically significant when we did that analysis.
Okay.
Very nice, Jessica. Thank you very much.
You're welcome.
So as we heard Dom just a minute ago, I'm guessing he's still online. So our next talk will be by Dominic Campano, who is going to talk to us about blood loss in TFNs with use of Bovie electrocautery.
Hey, good afternoon. Just again, thank you guys to UNM for speaking with us, and also on behalf of all the juniors for hosting the annual SWOTA conferences. I think I speak for my whole class that we enjoyed it. So is there a clinical difference regarding blood loss and approach to femoral nailing, scalpel versus Bovie electrocautery? So special, you know, credit goes to Kevin for kind of getting some energy behind this and getting a lot of people on board for changing our protocol. So first off, some of the important, you know, we're looking at IM nailing and the use of hip fractures. So with the very high incidence and high mortality of these geriatric population, we're looking at 300,000 over the age of 65 hospitalized for these injuries per year here in the U.S., with mortality rates ranging somewhere between 6 and 30%. It's been studied in depth, as you'd imagine and you well know. And, they've said, surgery within 24 hours of admission is associated with reduced complication rates, including length of stay and morbidity. And then other factors having implications are age, prefracture function, fracture type, as well as pain. Other things reported in the literature at depth in regards to hip fractures, you're looking at fast track protocols, time to surgery, whether or not you can get folks ambulating early. And the implication of that, people having more UTIs, having higher rates of pneumonia, increased lengths of stay. It's also been studied, short versus IM nailing, having less blood loss and faster operative times, different techniques, DHS versus IM nailing, whether or not TXA provides a clinical benefit, and a lot of papers out there say yes. And then, a lot of these elderly folks are on anticoagulation, most commonly aspirin when studied. And do you need to anticoagulate, reverse this anticoagulation? However, we're sort of focusing on blood loss here and trying to see if we can change our protocol in order to minimize this blood loss. So in regards to blood loss, TXA that's been studied has reduced blood loss from 88 mils in certain studies from their intraoperative blood loss. When they look at this between pre and post-op hemoglobins, they're looking at about a 2.5 grams per deciliter difference. And that's kind of along the lines of what we've seen here at our institution within the past year of data that we've begun to go through for 2019. So again, another paper has looked at extracapsular drops in hemoglobin, and the numbers are here, so 2 and 1.49 respectively. The nadir is approximately 2 days post-op for the decrease, and again, that's right around this 2.3. Most of these patients were anemic upon presentation, and so a lot of these folks required blood transfusion, and those will be some other things we'll be looking at. Again, some of the literature regards to short versus long nailing, they're saying with short nailing, you can save, 39 mils of blood with short nail, 19 minutes of operating time, and decreased transfusion rate. So what exactly are we talking about here? We're changing our protocol, and instead of using strictly a scalpel throughout the procedure, oftentimes, prior to this, Bovie was maybe open on the back table, but not exactly plugged in, or if it was plugged in, it wasn't really touched. And so we're looking at using, scalpel for the skin, but after that, dissecting down the greater trach with use of your Bovie electrocautery, and see if that can provide emphasis for, limiting that oozing, muscle bleeding, and overall blood loss. So we'll be looking at pre and post-op hemoglobins in regards to this, and measuring our surgical time. Whether or not, we would hypothesize that we'll save blood loss, but whether or not, we see a difference, I think no difference is going to be a clinical, have value clinically. And if we do have a difference, it's going to have value clinically. So either way, I think we can provide some valuable information for the literature. So here at our institution, we had 178 procedures pulled for the CPT code 27245 of intertroch, paratrochs, and subtrochs. And so that's the data that we'll be using for control to go back and look at retrospectively after we've collected our data from this. And so that's kind of our PSA, ongoing research, and teaser for future presentation.
How do you plan to measure the blood loss?
Yeah, so mostly just looking at pre-op hemoglobin versus post-op hemoglobin will be our main, value, just because of the whole ambiguity of physician estimated EBL.
And are you using a knife to make the initial incision and then switching to bovie? Are you using the cut function of the bovie to make your initial incision?
Yes, yes. So skin with the knife and then bovie from there on out.
Yeah, and the protocol says that I guess you're going to dissect using coag as opposed to cut.
Yes, sir.
Have there been any studies actually look at like an absolute change in hemoglobin and correlate that with blood loss? I mean, could there be other factors in there that change hemoglobin besides blood loss? Do you understand what I'm asking?
Kind of like IV fluids, dilutional,
Right, just because
as a factor.
Yeah, just because their hemoglobin's different doesn't mean they lost blood necessarily. I mean, it could be other factors.
Sure. And I think really that's just our best estimate, you know, and again, they can have blood loss from the fracture even before surgery, you know, and so that's why some folks have, you know, studied time to surgery as well as just blood loss after surgery, with the nadir being, you know, post-op day 2. So there's some bleeding post-surgical, but I think overall that's the best we can do, is just that difference of pre and post hemoglobins.
I think I'd be interested to take a patient, if never done, like take a patient, you know, have them donate blood, and and then check their hemoglobin, donate a unit, donate 2 units, donate 3 units, and then see what the difference is. Like, you come up with a standard correlation and see if there is something there. I don't know. Anyway.
I think what you'd really have to do to gain validity in this study is, because I don't think power will be the problem. I think the issue is going to be that you're going to need to propensity match this study with respect to patient characteristics and then fracture morphology. I think that's where you can really gain the validity in the study.
Yeah, and I think we'll stratify based on, you know, fracture pattern, intertrocks, etc.
Dom, can you hear me?
Yes, sir.
Have you noticed any? Okay. Have you noticed any difference in terms of post-op pain and rehab, comparing burning the muscle and cutting it with a sharp knife?
Not that I've come across, and not yet. Just kind of in our, you know, month or couple months of data so far, of experience.
Yeah, it'd be nice to see if how is the post-op pain comparing burning muscle and cutting it with a sharp knife, and the muscle strength maybe post-op, you know, after a few weeks.
And I hadn't come across anything like that in the literature, so I think that's a really good.
That's a good topic.
Good idea that you had to incorporate.
Okay. Thank you.
Any other questions?
Now that brings, yeah, that's interesting, because I just did an amputation when you know, sometimes I'll use bovie to cut the muscle, doing like a BK, and sometimes I'll use the knife. And I was thinking that just the last time I did an amputation, I was like, I wonder if there's really any difference. You know, either way, it both work, but I was wondering if there was a difference. And maybe McKee could chime in, like, you know, go through that and pain afterwards, because they're looking at some of those effects with so the nerves procedures are doing with these amputations.
It depends. For me, I like sharp debridement because most of these patients are trauma patients, and I like to see the tissue bleed freely. I don't want to leave questionable tissue. So I don't do a lot of cutting with bovie unless I'm in a blood loss situation that I need to avoid, or someone who's on an anticoagulant. I will use the bovie, not for cutting, but for muscle stimulation and just making sure I still have contractile muscle in places. And then of course for dedicated hemostasis, like if I have a spot that I see is bleeding, because I get hemostasis as I go. We use clips, we tie off vessels, we use bovie for directed things. But when we go on and off tourniquet, we've been in both of those situations, especially when I'm working on tourniquet. I'll let the tourniquet down before I'm done. But I have a better feel for what tissue is good when I sharply debride rather than using Bovie. And I just get hemostasis as I go. So it's one of those things where it may take me a little bit longer, but I clip and tie as I go to make sure I'm leaving only good tissue.
I think it's a big difference though with I mean, this is a procedure that is done radiographically and essentially percutaneously, and it's something that, you know, these patients do have blood loss and transfusion requirements and things like that, and it's the idea is to see if you can minimize that with, you know, with a Bovie, but you're never actually you never are physically looking at your insertion point of your nail that you're going down to or anything like that. You're just getting through the muscle and things like that. And so it's a little bit of a different animal from that standpoint.
Well, it's absolutely different. Just commenting on Dr. Jenkins talking about our amputations. Because the stuff you guys are doing, you're not going to, unless it's a horrible crush injury, most of the muscle surrounding your operative site is going to be intact and doesn't need to be widely debrided.
Dom, can you comment, are you guys excluding short nails or medium nails? Are you concerned that reaming the canal and putting a long submedullary nail might create a variable? So I didn't know if you commented on that as far as what the exclusion was regarding nailing.
That'll be something that will stratify short versus short and then long versus long. But yeah, definitely would have some implications for sure.
Dom, a little bit of a question, a little bit more of a comment. It seems like a study that's rife with confounding. I just think you need to be very careful in the way you set this thing up because, one, the fracture morphology, two, the surgeon doing it, three, their preoperative health status. All these are going to have very big implications in blood loss. The other thing is we are notoriously poor at estimating blood loss in a surgery, and I fear your numbers would have to be really, really high of patients to even see a little difference. And then there's just so many variables involved with this procedure that you're not accounting for with that one portion of the procedure. So I just, in your study design, you need to be very careful because you can really get trapped in the weeds and really find not a whole lot of difference if you're not careful with controlling for confounding.
Definitely.
Well, thank you for all the comments. Dominic, thank you very much for the presentation. We're going to move on now to Sai Daneshvar. He's going to talk to us about vertebrolectomy, instrumentation, and interbody cage placement through a posterior approach for traumatic L5 burst fractures.
Thank you, Dr. Grimes. Can everyone hear me?
Yes, sir.
Okay, so I'm going to talk about vertebrectomy instrumentation and interbody cage placement with a technique utilizing a posterior transpedicular approach. First, it allows you to preserve your L5 and S1 nerve roots. And this has been a case series that we've kind of started since I started residency with Dr. Felton, and now that Dr. Groschmal is here. We are continuing this case series. We initially wrote a technique article with a case report of our 3 patients that we have so far, and we're going to continue this in a retrospective series as we kind of continue, and then hopefully maybe if we don't have enough power by my chief here, we can pass this on. So kind of beginning with an outline, we're going to talk about just the overview of the case study, biomechanics of lumbosacral anatomy, and then indications for the operative treatment of severely comminuted L5 burst fractures and kind of how that is changing with respect to the literature, current literature, or in a lot of ways, the lack of it with regard to kind of what we're discussing regarding the technique, the current case study, the technique that we're utilizing, and then the current status and where we're going to go from there. So initially, our manuscript that we submitted to the Spine Journal last month was a case report series of 3 patients with current literature review who underwent L3 to S2 posterior spinal fixation and decompression, along with the corpectomy through a transpedicular approach, and then interbody cage placement with in situ actual fixation of our interbody cage. And so what this allowed us to do is actually spare our L5 nerve roots, which traditionally utilizing a posterior approach had never been done or reported before. And so for current literature, posterior approaches have been done for complete nerve root injuries or for cases involving tumors and whatnot, where you have respective discitis and complete collapse, or what is attributable to a complete cord injury. Whereas a 360 approach, utilizing a retroperitoneal approach where you sacrifice the anterior longitudinal ligament, which destabilizes the anterior column natively. And it also kind of presents what we've described utilizing our technique article to actually make it quite difficult to match the patient's lordosis, because you actually don't have an anterior restriction point in which to place your cage, because most of your shear forces are actually anterior at the lumbosacral junction. And so classically utilizing TLIX as a reference point to determine whether or not a burst fracture should be fixed or not, one of the main deciding factors is actually whether or not the posterior ligamentous complex is intact or not, which if you really look at the anatomy, a lot of papers have discussed that may not really be attributable to an L5 burst fracture, that actually also that involves sacral fractures and whatnot, given this anatomy. Also utilizing a 360 approach where you use a retroperitoneal anterior approach, you increase your operative time, increased potential morbidity, increased operative bleeding, risk of retroperitoneal bleeding, and then increased, not aortic injury, that should be common iliac injury. So kind of going into that anatomy, kind of briefly, I touched on this. So with the lumbosacral region, you have a maximum flexion extension arc of motion of about 17 degrees within the sagittal plane. Rotation is minimal of about 1 degree, and then lateral bending with respect to your facets is about 3 degrees. Your L5S1 disc is the most anterior curved disc in the entire spine. And so there is significant amount of load, and actually it contributes to the most load based on human beings, which are bimodal ambulators. And so there is a high level of shear force given the angulation and anterior angulation, which for retropulse burst fracture utilizing a TLIX score kind of necessitates, especially when you have greater than 50% loss of height, the use of an interbody cage. And so, you know, some of the difficulties with treating L5 burst fracture is that it's difficult to manage these non-operatively, given the fact that you're unable to effectively immobilize with a TLSO. A lot of times this requires a hip spica component, and then you have problems with patient compliance. And so kind of with this, you know, the biomechanical stresses, considering a stable fixation, your sacrum also has poor bone quality. And so you have large loads and increased risks of cantilever pullout forces with just posterior spinal fixation. And so that's the reason why interbody cage is used to stabilize and develop an anterior strut, which actually helps limit the load on posterior fixation and your pedicle screws. Associated complications are your failure of instrumentation, loss of sacral fixation, which is why for our studies, we are actually using pretty much SI screws through the S2 body, and then loss of lumbar lordosis, and then utilizing our technique, keeping the anterior cortex and our ALL allows us to kind of view that, and we can actually match the lordosis of the patient in situ by assembling the cage within the actual vertebral space. And then due to these cantilever forces, there are high rates of pseudoarthrosis. So kind of indications for L5 burst fracture treatment are a TLIX score of 5 or higher. Kind of, again, this is kind of changing the opinion. Now there's varying opinions on this, but for TLIX was historically used for conus medullaris syndrome and for determining whether or not that you wanted to fix in the thoracolumbar junction. And L5 is very different. So a lot of things that you would try to use to determine whether or not a patient should be fixed or not isn't the case. You're also outside of the spinal cord. So really what you really should be looking at with terms of neural injury is whether or not the nerve root is intact or not. And so fixing this is indicated when there are neurologic deficits that can be caused by anterior compression or that bony retropulsion. And so scientific data to date has not shown whether or not early decompression stabilization is beneficial to return of neurologic function. And it's one of the things that's kind of been difficult for us with literature review, because most of the time when they describe a posterior approach, they don't describe any return of neurologic function because the nerve roots historically have been severed, because classically you were unable to assemble a cage in situ and preserve the nerve roots. And so complications associated with that are dural tears, iliac injuries, pelvic plexus injuries, and then continued radiculopathies as a result of that nerve root injury. And so this kind of describes, to date, existing literature based on our review describes that repair of L5 burst fractures kind of fall into these two categories: utilizing posterior instrumentation plus or minus decompression, and then utilizing a vertebrectomy with an anterior approach where you go through the ALL. So on our current study, our first patient is a 19-year-old male involved in an MBC who sustained an L5 burst fracture with retropulsion of about 70% of the canal and 50% loss of height. Here are his injury films in the sagittal and axial planes. He had an initial TLIC score of 6, and he had numbness and paresthesia in the L4 and L5 nerve distributions. Rectal tone was intact, and his exam, it's not a spinal cord injury, but if you had to make it, it's consistent with an age of D injury. He also had hypoesthesias, but preserved motor function and exhibited weakness that was increasing from 4 to 3, so he was taken back. And I will describe that construct. Our next patient, similar presentation, similar mechanism of injury, less loss of height and less compromise. However, given the fact that the patient was a polytrauma and the patient had a poor initial neurologic exam was difficult. However, the neurologic exam following extubation was poor, which prompted fixation by Dr. Felton. And our last patient is a 21-year-old male involved in an MBC that had 90% canal compromise and 50% loss of height. There was no initial myelopathy, but paresthesias and significant radicular pain that was localized to the gastroc. And so utilizing our construct, the patient is placed in a prone position and there's a posterior exposure of the L3 to S2 spine. Utilizing our O-arm and navigation, we placed our pedicle screws and our rod instrumentation in our levels 3 and 4, the lumbar spine, S1, and then a sacroiliac screw was placed in the S2 body. And then a corpectomy was performed with the transpedicular approach, and pretty much you would do a complete superior and inferior discectomy, and then with use of nerve root retraction, preserve those nerve roots, and kind of looking here, you keep that anterior cortex and the ALL intact, and assemble this cage through and I guess on the patient's left side, which is the side that neurosurgeon stands on typically, with assembly of our interbody cage. And you kind of see this is where we're trying to actually match the patient's lordosis. So this is initial, and this is actually where we're actually uplifting our interbody cage. And so with the final construct being this, with fixation of L3 to S2 with transiliac screws, and then our interbody cage. And so our results to date, so all patients have retained L5 and S1 nerve roots, and there's been no loss of fixation, no lordosis or pull out of hardware, no prosthetic infections have been noted to date, and our follow-up so far has been 3 to 38 months of our 3 patients. In similar studies, anterior corpectomy studies demonstrate 95.1% rates of fusion, and the highest power study so far that I have found is 19 patients with a similar traumatic L5 injury, no loss of fixation and no pull out. However, they did not really discuss neurologic status or whether that had improved or not. To date, 2 out of 3 of our patients have achieved 5 out of 5 lower extremity strength on clinical exam. 1/3, which was our polytrauma patient, our second patient that I presented, has some residual L5 weakness and presents a 4 out of 5 clinical strength. And so with the mean follow-up time of 19 months for the 3 patients so far. And so with the status of our study, our manuscript with our technique article and our case reports for our 3 patients was submitted last month and is in the review process. And then our retrospective case series is continuing this study for long-term follow-up and outcomes compared to a 360 approach with the retroperitoneal anterior approach as a reference standard to compare return or preservation of neurologic function with respect to clinical exam or with use of nerve conduction study. And then morbidity associated with the surgery, which would be increased surgical complications, increased blood loss, and then also complete failures of fixation, that being pseudoarthrosis, loss of lordosis, or a proximal junctional kyphosis. And so our literature is limited for long-term neurologic results for respect to this specific injury, and most studies have focused on fusion rates. So that has been the difficult aspect of the study. So it's going to require a little bit more work, but that is our plan so far and where we're planning to go with this. And these are my references. And if anyone has any questions.
Any questions or comments for Dr. Daneshvar?
All right, thank you, everyone.
All righty. Well, if no one has any comments for him, we're going to move on to Dr. Andrew McKeska. He's also going to be one of our third years, and he's going to talk to us about continuous external tissue expander to assist total knee arthroplasty wound closure. There we go.
All right. Let's see this. Can you guys see that okay?
Yes, sir. We can hear you and the screen looks fine.
Okay. So, yeah, my project was over the use of continuous external tissue expanders assisting total knee wound closure. Real quick, we'll go over the history of total knee wound complications, the mechanism of these continuous external tissue expanders, goals of our study, methods, the results that we have so far, and conclusions, and then we'll answer some questions. So for a procedure that's done very commonly, the overall infection rate remains high. In literature, it's reported anywhere between whatever it is 1 to 3%. The article I found was a 1.25%. The risk factors for these, each of these risk factors has, I'm pretty sure, been independently studied in different papers and been proven to increase the chances of wound complications. But prior open procedures, poor nutrition, including albumin levels below 3.5 or a pre-lymphocyte count of less than 1,500, obesity, which is an exclusion criteria that we frequently use at our institution with a BMI limit of 40, diabetes, mellitus, especially with A1Cs, above 8, be careful of those patients. And then any history of smoking or immunosuppressive therapy that may cause those tissues to have trouble healing. Post-op hematomas have also been proven to cause these complications. So how does this device work? So essentially what it does is help relieve tension from the incision itself and use that tension or distribute it around the tissues surrounding that incision. So whenever you're applying these devices on a total knee or a revision total knee, what you do is you surgically undermine the dermis surrounding the incision, place these anchors approximately 2 to 3 centimeters apart, and they have little barbs on the bottom of them that go approximately 0.5 centimeter in depth. And then you set the tension controller, and what you do is it's kind of like a ratchet type device, and then it'll begin clicking once it has a constant tension of 1.2 kilograms across the wound. And as the wound actually shrinks or it gets closer, it'll keep that same tension so that you're still applying an appropriate amount of force on the surrounding tissues. And the basic science aspect of this is that it helps align that elastin and collagen bundles and lengthen them, providing a slow stretch over time and giving you more tissue to work with. There's been a lot of other reported literature reports that say, they use this in fasciotomies and things where they have actual wound defects. And there's been one paper where they use it in the same aspect that we're using it, which is to unload that incision site, which was in total ankles. So goals of our study, we want to evaluate the complication rates and types of high-risk patients undergoing total knees with the use of these continuous external tissue expanders, evaluate the time to healing in these patients, and then eventually, once we have enough patients, compare these outcomes to those using only traditional closure methods in these high-risk patients. So study design, this was a prospective chart review. It's a single institution done here. These patients have undergone a total knee with the use of the CETE. The study population, any males or females, up to 81 years of age that are considered high risk, as defined by those variables we included earlier. Ultimately, this was an intraoperative decision as to whether or not this device was going to be used after assessing the tissues and looking at their quality throughout the surgery. And then we are using this on either primary and stage 1 or 2 revision total knees. So the data we collected, we are comparing the age, gender, intraop wound size, time to healing, and post-op complications. The time to healing is defined as whenever we have written documentation that the patient's incision has been evaluated in clinic and is healed, as in that they do not have any draining wounds and that there is no needed sutures or anything to keep that wound closed. So the results that we have so far are a total of 7 patients, 3 males, 4 females, average age of 64. Our intraop wound size average was about 15 centimeters with a range of 10 to 25. The mean time to healing that we have documented is about 38 days and ranging from 20 to 64. And the wound closure achieved was approximately 86%, and we had 1 patient that required further procedures to ultimately achieve wound closure. So going forward, we just need to continue to collect more patients and increase the power of the study. I think this study has the potential to move forward with the looking at different procedures to see what type of procedures would show a significant benefit. You could use this in hips and spine procedures, and even different type of procedures and like total ankles. I know that's been done, but similar things to that. We're planning on, I already submitted this abstract for a poster presentation to COS. And due to the current COVID situation, that's kind of been put on hold, but we'll see what opportunities there are in the future. And then target journals, ultimately JBJS would be nice, Journal of Arthroplasty, and then also the Journal of Wound Care would be a potential literature source as well to apply this to. So here are our references for the presentation. Does anyone have any questions?
Andrew, are you comparing this to a control to your standard wound closure?
So what I would imagine we'd do is compare this to another paper where they had standard type of patients with that were considered high risk with wound closures, or we could do a retrospective chart review and pick out patients that had similar qualities or comorbidities as the patients that we use these on and see how they did. I feel like there's multiple ways to kind of compare how this affects the wound healing in the knees.
Do you know the cost of it?
No, I don't know the cost of each device. I'm not sure.
Do we have any other questions or comments for Dr. McKeska?
Andrew, real quick. I think kind of the way it will end up being designed is more of a case control, where you have each of these cases and you have to match to another kind of high risk patient, being more of a retrospective than a prospective, which you stated. It's kind of, it will eventually, I think, be a more of a retrospective review than a prospective type paper. But that, I think, yeah, I did kind of like Dr. Ferguson was alluding to. I mean, type of control group would be important, kind of case match for high risk wounds to kind of really say this makes a difference.
Okay.
And you're selectively choosing to use this device on those patients that you're concerned might have a post-op wound complication. Is that correct? Ones that you've identified intraoperatively that are concerning. You're not necessarily using it on patients that you're not concerned about wound healing.
Correct. Yeah, for high risk wounds. So yeah, morbidly obese, revisions, vascular issues, wound kind of high wound tension due to skin loss from multiple previous procedures or incisions around the knee.
A lot of our patients had previous wound complications, and then we decided to give these devices a shot to see if they would heal successfully. So.
All right. Well, thank you very much, Dr. McKeska, and thank you for the comments. We will now hear from our last speaker, Stephen Sierra, who also is about to become a third year. And he's going to tell us that the hemoglobin A1C is not associated with risk in upper extremity surgery. So. Stephen, we're not hearing you. You're muted.
So again, I'll be talking about elevated hemoglobin A1C. That's not an associated risk factor with post-op complications and elective hand and upper extremity surgery. So just a quick little background. It's historically noted that diabetic patients compared to non-diabetic patients do have increased risk of post-op complications, and these can vary from just about anything, but the big one we worry about is infections and wound healing, or that's one of the big ones we worry about. An American Diabetes Association recommends that patients' A1C is less than 7. Different places have different rules, but some would make this a cutoff for maybe 7. I mean, that seems a little aggressive, but some can have a cutoff of up to 9%. It just kind of varies on it. And some people don't even have a cutoff for these, but literature is pretty unclear of the predicted value of hemoglobin A1C for post-op complications. There's a lot of mixed results saying that it is predictive, and some say that it's not. But we weren't able to find anything in the hand and upper extremity elective surgery literature that analyzes this. So this is something we figured could be important in patient selection. So again, the purpose of this study was to evaluate the association of hemoglobin A1C levels with the risk of post-op complications. So this was IRB approved patient selections. It included patients who underwent common surgeries, which is on the right. They were performed all by the single fellowship trained surgeon from 2012 to 2018. There was a pre-op and post-op group. The pre-op group, the hemoglobin A1Cs were recorded within a year pre-op, and the post-op group were recorded up to 3 years after. So we followed them for 3 months post-op. or at least that's how much we did the chart checks of. And complications that we included were infections, dehiscence, or unimproved or worsening post-op complications or symptoms. And the cutoff values were 6.5 to 7, 7 to 8, 8 to 9, 9 to 10, and greater than 10. So as a result, we ended up finding that there were 22 complications at 3 months post-op. Infection was at 31%, and the rest of them, the complications were no improvement or worsening of symptoms, which was up to 68.2% of the 22 complications. And we found that the hemoglobin A1C at the cutoffs were not, were not significantly correlated with increased rates of complication. So just moving on to the discussion, it is known that nobody wants their patients to be in a hypoglycemic environment, and surgery. In a perfect world, everybody would be non-diabetic and not have this problem at all. But in the world we live in, it's just very common. So it is something we have to consider. But even in other literature, at least the one that we kind of saw was, so in foot and ankle literature, it's known that there are a lot more important things than hemoglobin A1C, like peripheral neuropathy, which is a stronger predictor of post-op complications. And A1C is not the only cutoff people use. Obviously, weight, BMI is considered, and also cigarette smoking. And a lot of discussion is that these are considered modifiable, and to most, or not most people, but a lot of us, it seems like, okay, if I needed surgery, I would just go lose weight or stop smoking. But there's a lot of people out there that either try really hard or they're just not well educated enough to even go about doing it. So these hard cutoffs, if you have them, they kind of de-individualize the patients. And so a lot of patients that need surgery and they would have tolerated get turned away. And a lot of people, there are known factors that influence outcomes like anxiety and depression, but these are rarely denied. And I don't think I've ever seen a surgery denied because of depression or anxiety. And also some of these surgeries like trigger fingers, carpal tunnel, guions, cubital tunnel are, they can, really mess with your hands. And if your physical aptitude is kind of what brings home the paycheck, it's very important to get it done. But if somebody's like, hey, I'm not going to touch you because your diabetes isn't controlled, then you're kind of losing a lot from that, even if you try to get it under control and it's not. So in conclusion, the study kind of helps address the utility of hemoglobin A1C as a pre-op qualification for surgery. And we found that it was not a significant predisposing factor. And just kind of recommend that surgeons regard it more as just a puzzle piece and not an independent gatekeeper in performing surgery. We're not saying don't consider it, because it is something you should look into, but just kind of take the whole picture instead of just looking at one value. And references, and thank you. And thank you, Dr. Skank, for the discussion earlier. We appreciate having you.
Oh, you're welcome. It's been great listening to all the talks, and enjoyed being here today. So thank you.
Appreciate it.
So Stephen, you went very fast by it, but the hemoglobin A1C reflects the glucose over a 3-month period. And it looked like you were collecting the glucoses over a very large period of time.
Yes, sir. And that's one of the limitations. Ideally, everybody would have had it right at 3 months before surgery, but just going through all of them, we just couldn't get enough people that were exactly at 3 months. So it kind of expanded, and especially the post-op ones, I guess we're just kind of assuming that's relatively to where they stay at, which maybe is a bad idea, but that's just what we had.
That is one very big limitation, because this is a retrospective study. And so we're actually going back through the data, because each of the diabetic patients had their blood sugar checked on the day of surgery. And so we're making a new category, showing what patient's blood sugar was on the day of surgery as well. And I personally, will do these procedures on people with elevated blood glucose up to between 300 and 350. Beyond that, I just tell them they're rescheduled. But we started looking at this because other hand surgeons in the country would be like, yeah, if they're over 7.5 or 8%, they don't get their trigger finger release or their carpal tunnel release. And so these patients, you know, if I did that in my practice, these patients would end up with this terrible carpal tunnel that just got worse and worse and worse until that nerve had been pinched for so long that even surgery wouldn't correct it. And so I've never limited my patients based on their hemoglobin A1C, but I did notice that other surgeons were doing that. And I just didn't agree with it because I've never had to take anybody back for an elective surgery post-operative infection. The few things that we thought maybe were getting infected, we jumped on them early, gave them antibiotics. You know, and I looked at the numbers, and out of those people in this study, those 930 people, those 1,447 procedures that we looked at, we had a 0.7 infection rate, which is quite low, and we found no difference in our diabetic versus non-diabetic patients. So we were trying to find a way to tell other surgeons, hey, you don't have to have this cutoff for these elective procedures in these patients. They may never get helped if they don't get their sugars under control. And so it was you know, we wanted other people to consider, yes, glycemic control is important, but don't knock your patient out of the surgical schedule based on that one number alone. But we've submitted it for publication, and we're going back and we're getting the day of glycemic values, and some of the suggestions have been to look at the duration that the patient has been diabetic, and to get more details about the patients themselves, which may or may not be possible. As you know, we've included patients in this study over a multi-year period. So it may turn into something that we put back together as a prospective study and make sure that all these patients have, you know, not only a blood sugar on the day of surgery, but a hemoglobin A1C within that 3-month period, either before or after the surgery. Because yeah, that's a limitation. Basically, the only thing so far I've been able to show with this study is that, you know, all my patients seem to do the same whether they're diabetic or non-diabetic. We haven't had the diabetic group show up with a lot of infections.
I think this is an example of applying something in another area of the body and trying to extrapolate it, because, you know, in foot and ankle, wound complications are much higher incidence than in hand surgery. And we deal with a lot of complications of diabetes. And so, you know, the hemoglobin A1C shows a more significant effect for us than it probably would in other areas.
Yes, exactly.
And so one of the things in our field that has been shown, I don't know if it's been published, but it's been presented at meetings, is that if patients are motivated to have their surgery, there is a observed effect on their hemoglobin A1C if it's used as a gatekeeper. And so it can be a motivating factor for diabetic control. Even if you can't get them down to the ideal 7, you can get that lower and lower the risk of a complication.
Yeah, I agree. I think that people have extrapolated this to areas where it doesn't necessarily belong, you know, and then you have the ADA, your American Diabetic Association, you know, with their recommended target hemoglobin, and then you have suggestions that you shouldn't have surgery in these patients who don't meet the goal. So given the lack of literature in the hand and upper extremity world, we were trying to put a little more information out there to the current body regarding this specialty. But yeah, definitely retrospective has limitations.
Yeah, I mean, just anecdotally, if you see like these polytrauma patients that have high hemoglobin A1Cs, uncontrolled diabetes, it's not uncommon when you operate on their like forearm, humerus, shoulder, hands, those tend to heal, but you still have extremely high complication rates when you start to operate on their tibial plafons, calcaneus, their feet. Those wounds seem to break down much more often, at least in my clinic. So there's a definite difference between the upper extremity and the lower extremity when it comes to diabetes and where you're going to have those complications, just from my experience over the last 12 to 14 years.
Well, the other big difference here, Mark, is that this was only elective surgery. We're not going to include the dirty open fracture. And plus, the trauma population is its own special population anyways. right? In general surgery, we say that trauma is its own disease. This only included trigger digits, carpal tunnels, cubital tunnels, LRTIs, decor veins, Guillain release, ulnar nerve transposition, radial tunnel, styloidectomies, carpectomies. And I did include my joint replacements that I do in the hand. So, I mean, this was just elective upper extremity surgery.
Yeah.
So no trauma. Trauma's its own deal.
Yeah, I agree with that. But what I'm saying, you have a patient come in, when they get infected, it seems like it's 95% of the time. They might have a terrible open, nasty forearm, but you fix it, and those very rarely get infected. But if they have a open ankle fracture, those seem like they almost routinely get infected, especially if they have comorbidities on the same patient. So there is a difference. I'm not sure exactly why it's as pronounced as it is, but I would say there's a difference whether it's elective or not.
Well, blood supply is a pretty big issue. And with the number of lower extremity vasculopaths out there, that does make a huge difference, because you don't have, unless you're actually on dialysis or dying and septic in the ICU, blood flow in the upper extremity is not a problem. So that's one of the big separations between upper extremity and lower extremity.
We potentially could do the same study with shoulder arthroscopy, because on occasion, rotator cuff repairs arthroscopically will have patients with a hemoglobin A1C in the 8 and 9 range. And I haven't noticed any, I've only ever had to take one shoulder arthroscopy back, and that was for a open biceps tenodesis that was infected. And so with the shoulder surgery that I do, I haven't seen a very high infection rate with diabetic patients and doing arthroscopic cuff repairs.
Yeah, and so basically we're adding to the body of literature, which again, there wasn't much out there on upper extremity. And, like Dr. Graham said, you could maybe hold off on the surgery for a while to help them want to promote their own glycemic control. But, if you just use that number as a hard cutoff, which some surgeons are doing, I don't think that's being used very effectively. And I think we need to get some prospective data to make this more effective and more legitimate.
Yeah, I agree. I don't think there should just be a broad brush to say if your A1C is this, you don't get any surgery. I think what you're showing is there's obviously some surgeries that are safe to do and probably shouldn't be delayed. Jordan, are you still there? I was just curious, is there a difference between total hips and total knees on the hemoglobin A1C as far as which, is that a risk factor, and is it different between those two surgeries? I don't know if he's on there.
It says he's on here.
He snuck away.
He had to use the restroom. Leave him alone.
All right. Are there any other comments for Dr. Sierra? I want to thank all the residents for getting together their presentations, and I look forward to seeing their publications that come out of these presentations. Dr. Skank, again, thank you very much for joining us. It's always a pleasure to hear your speeches.
Yeah,
and thank you for having. I'm sorry, Dr. Jenkins.
I was just going to say that it seems like the research is getting better and better. I would like to just say shout out to Dr. Karoum. I know he kind of pushes hard for the guys to get the work done. And another thing, I think our hand surgeons, specifically Dr. McKee and McKay, they've really started to put out a lot more research, and I think the quality is getting better. And as a program director, we were cited for almost 8 years, 10 years for lack of academic production, and we're off. We don't have any warnings now, and so I'd just like to thank those people that are working on this. It takes a lot of time and effort to get this done, and I appreciate that.